Welcome back to Open Med School. Today I am going to discuss with you the basics of adrenergic receptors and drugs acting on it. This is part of Pharmacology Simplified. Our autonomic nervous system is divided into sympathetic and parasympathetic, having exactly opposite actions. Sympathetics are for fight, flight, fright reaction, and parasympathetic is for digestion and rest. That is the basis that we have studied in physiology. A brief outline about the arrangement of the autonomic nervous system and the drugs acting on it. The autonomic nervous system has got the parasympathetic, which has got a craniosacral outflow. That is, outflow is from the cranial and also from the sacral region. Whereas the sympathetic has got thoraco-lumbar outflow. That is one of the fundamental things that we should remember. Here you can see that the basic arrangement of parasympathetics and sympathetic are same. Parasympathetic has got a long preganglionic neuron with a smaller or a shorter postganglionic neuron. Whereas the sympathetic has got a shorter preganglionic. You need to remember the parasympathetic ganglia are in the paravertebral region, which is very close to the spinal cord. So it has got a small shorter or short preganglionic neuron, which relays in here and it goes to the effector organs. And the parasympathetic has got a more localized effect. That is why here this neuron, the ganglia are situated closer to the effector organ. So this is the basic principle that you should remember. Because sympathetics are for once it is activated, it has got a larger area of action. That is, we need for fight, flight and fright. So this is an activation of a lot of organs are required. Whereas parasympathetic has got a very specific action. For example, if you want to have salivation or if your gastric motility is required, all these are having, or the intestinal motility, more localized actions. Hope this point is clear. Again, one more thing you should remember, that is the preganglionic, the neurotransmitter is always acetylcholine. That is another concept you should keep in mind. That is the preganglionic neurons, whether it is sympathetic or parasympathetic, the neurotransmitter is acetylcholine. The third point which you should remember again is that in sympathetic system there is an exception. Sweating is by cholinergic sympathetics. That is, the sympathetic nerves are supplying the sweat glands, but the neurotransmitter is acetylcholine. Hope it is clear to you. That is all the preganglionic, sympathetic versus parasympathetic, the neurotransmitter is acetylcholine. In the postganglionic neuron, the sweat glands are supplied by cholinergic sympathetics. What do you mean by cholinergic sympathetics? These are sympathetic part of sympathetic nervous system, but is supplied by the acetylcholine. These are the, and again the adrenal medulla. Again you can see that there is a preganglionic neuron. Here the postganglionic neuron is not there. It is secreting the hormone or the adrenaline and noradrenaline into the circulation. So medulla is also, adrenal medulla is also comes under part of the autonomic or a sympathetic nervous system. This is what I already mentioned. The preganglionic sympathetic nerve fibers secrete acetylcholine. The postganglionic sympathetic nerve fibers, except the sweat glands, the neurotransmitter is noradrenaline. It's a fundamental point. The neurotransmitter in sympathetic postganglionic neuron is always noradrenaline or norepinephrine. Exception is the sweat glands, which are supplied by cholinergic sympathetic. That is, acetylcholine is the neurotransmitter. Now we go into the classification of the adrenergic receptors, otherwise called adreno-receptors. Basically, they are divided into the alpha receptor and beta receptor. Alpha is again divided into alpha 1 and alpha 2. Beta is divided into beta 1 and beta 2. There are subdivisions for the alpha 1A, 1B, 1D, same way alpha 2A, alpha 2B, alpha 2C, about which we will study later. The beta receptors are B1, beta 1, beta 2 and beta 3, which is of less importance. So basically divided into alpha 1, alpha 2, beta 1, beta 2, beta 3. Alpha 1 is again divided into 1A, 1B, 1D, and hope this point is clear to you. There are various subdivisions for the alpha receptors and beta receptors. Now we go into what are the effects of activation of the adrenoreceptors. So we have mentioned the alpha receptors are alpha 1 and alpha 2. Alpha 1 activation leads on to vasoconstriction. So once the blood vessels are constricted, what will happen? You get an increase in the blood pressure. So alpha receptors produce a vasoconstriction. Second, it produces relaxation of the gastrointestinal smooth muscle. So we have already said it is a fight, flight and fright. So if your gastrointestinal system is activated, once the adrenergic system is activated, it will be very difficult for the animal to run away. That is why it produces a relaxation of the GI smooth muscles. And it increases, facilitates a hepatic glycogenolysis. That is when during the exertion or fight and flight you need more glucose. So alpha 1 activation produces hepatic glycogenolysis. Hope this point is clear to you. The alpha 2 receptors activation produces the reverse effect. It produces inhibition of the neurotransmitter release, including noradrenaline and acetylcholine. So, contrary to the effects of the alpha 1 receptor, alpha 2 receptor activation leads on to inhibition of the release of neurotransmitters. It produces platelet aggregation, contraction of the smooth muscles, and inhibition of the insulin release also. So, remember that alpha 2 receptor activation inhibits the release of neurotransmitters. That is the basic thing. The rest of the things we'll study at a later time. Now we go to the beta 1 receptors. Beta 1 stimulation leads on to increased heart rate and force of contraction. That is, it increases, it has got a chronotropic and inotropic action. That is, beta 1 stimulation leads on to increase the heart rate. It increases the force of contraction. So when the patient has got a BP fall or when there is bradycardia, a beta 1 receptor stimulation leads on to increase in the heart rate and increase in the force of contraction. Beta 2 receptors is mainly for bronchodilation. Contrary to the alpha stimulation, beta 2 stimulation leads on to vasodilatation because it produces relaxation of the smooth muscles. Again, it produces hepatic glycogenolysis. Beta 3 receptors is concerned with lipolysis. So, beta 1 receptors mainly act on heart, chronotropic effect and inotropic effect. Beta 2, remember, bronchodilation. It can produce vasodilatation and relaxation of the visceral smooth muscles. So this is summary of the alpha 1, alpha 2, beta 1 and beta 2 receptors. So alpha 1 is mainly for vasoconstriction. So once it vasoconstriction, it increases the peripheral resistance and it increases the blood pressure. So remember, alpha 1 stimulation leads on to vasoconstriction and increase in the blood pressure. It acts on the eyes where the radial muscles on the iris. So they will contract and it will produce pupillary dilation. That is, it produces dilatation of the pupil. So alpha 1 stimulation produces mydriasis. And the prostate or internal sphincter, alpha stimulation leads on to closure of the internal sphincter. So the bladder is there, bladder has put an internal sphincter, the smooth muscles. Alpha 1 activation leads on to increased tone of the internal sphincter. So when the animal is running fight-flight reaction, the urination is prevented by stimulation of the alpha 1 activation. Now we go to the alpha 2. It produces, as I already told, it inhibits the release of neurotransmitters. That is, norepinephrine release is inhibited. It inhibits the release of acetylcholine in the preganglionic. It inhibits the insulin release. Everything is inhibited. We will come to the alpha 2 separately. Beta 1 already mentioned, it is active on the heart, it increases tachycardia, that is the heart rate is increased, lipolysis, increase the myocardial contractility. These are the two important things you remember. Tachycardia, increase the myocardial contraction, and it increases the release of renin from the juxtaglomerular apparatus. So beta 1 stimulation is mainly for blood pressure, facilitates the blood pressure maintenance, cardiac activity, increases the heart rate, force of contraction. Beta 2 stimulation is mainly, remember, bronchodilation. That is a major action. The major action is it also produces vasodilatation. Depending upon the various effects, it may mildly, it will, because of the vasodilatation, it can slightly reduce the peripheral resistance. And again, just like other receptor stimulation, there is a glycogenolysis, and it will increase the release of glucagon. So we know glucagon is an antagonist of insulin. It will produce hyperglycemia. So again, it is helpful that beta 2 stimulation leads on to glucagon release. Another important thing is, remember, this beta 2 stimulation leads on to relaxation of the uterus, tocolytic action. So the uterine action, beta 2. So again, we will study this, and individual drugs are there. Now a little more about the alpha 1. Alpha 1 receptors are in so they take us the synapse. Alpha 1 is post-synaptic and alpha 2 is presynaptic. That's an important point to remember. Alpha 2 is presynaptic. Alpha 1 is postsynaptic. So alpha 1 action is postsynaptic. It produces contraction of the smooth muscles or the blood vessels. I already mentioned it contracts the blood vessel, the vasospasm, and vasospasm leads on to increase in the blood pressure or vasoconstriction. It produces contraction of the radial muscles of the iris, that is pupillodilator fibers. Then they are contracting, it produces pupillary dilatation, mydriasis. And some drugs like phenylephrine drops are used for the pupillary dilatation. This is a phenylephrine. Ephrine is used for mydriatic action. So alpha 1, again I would like to stress the point, alpha 1 receptors are postsynaptic. Alpha 2 receptors are presynaptic. So here you can see it is a presynaptic. So alpha 2 is in the presynaptic region. It inhibits the release of neurotransmitters. So what will happen? It will decrease the sympathetic outflow. It will decrease the release of insulin. So almost opposite action of a expected response of sympathetic stimulation. One prototype of drug we should remember is clonidine. Alpha-methyl dopa is another drug. You should remember. Alpha-methyl dopa. Hope this difference is clear. Alpha 1 is postsynaptic and alpha 2 is presynaptic. So this is the neuron. It is producing synapse. So this is the alpha 1 is presynaptic, alpha 1 is postsynaptic and alpha 2 is presynaptic. Remember this. Now we look into in heart, which is the major receptor. It is beta 1. Remember this. In kidney, which one? It is again beta 1. So beta 1 stimulation produces increased heart rate, increased force of contraction, that is inotropy and chronotropy. It facilitates by acting on the juxtaglomerular apparatus. It facilitates the release of renin. So renin secretion is important and sympathetic activation leads on to increase in the renin synthesis and can lead on to increase in the blood pressure. So I already mentioned the beta 1, it is in the heart and kidneys. Remember, this is a cardio-renal. Remember this terminology, cardio-renal. That is beta 1. Renal is required for the secretion of the renin. That is why it is a protective for the maintenance of the BP. Many drugs are there, the prototype will be. So beta 1 stimulation leads on to increased cardiac activity, increased renin release. Isoprenaline is an example of a selective beta 1 receptor agonist. Isoprenaline. Now we go to the most important thing, the beta 2. Where is the beta 2? Remember, lungs. Lungs, that is bronchodilation. Beta 2 stimulations. I already mentioned uterus. That beta 2 stimulation leads on to uterus relaxation. Beta 2 is there in the liver. Increased glycogenolysis. In the brain also, the beta 2 receptors are there. Beta 2. And the synapse, beta 2 is there in the neuromuscular junction. Again, there is a beta 2. So let us look into the beta 2. Beta 2 is in the bronchi, blood vessels of deeper tissue. That is why beta 2 stimulation can lead on to decrease in the peripheral resistance to a lower extent. Very important, remember, uterus. In the liver and skeletal muscles, it produces glycogenolysis. In the presynaptic neurons or the peripheral neurons, it increases the neurotransmitter release. In the brain, it increases the sympathetic outflow. So beta 2 is little more present in the other tissues, whereas beta 1 is mainly for cardiac and renal. Beta 1 is mainly cardio-renal. Beta 2 is almost present in most of the tissues, especially remember the bronchi, the uterus, liver, presynaptic neurons and peripheral neuromuscular, that is in the muscles also. It is present in muscle and liver. Remember these important points. Then beta 3 is mainly not much. This is the lipolysis, and remember all are G protein related. The all subtypes of alpha and beta receptors belong to G protein coupled receptor family, about which we will study later. Alpha 1 is activating this mechanism is through the inositol phosphate, and the alpha 2 receptor inhibit the release of adenyl cyclase, and so the cyclic AMP formation is decreased. All other types increase the adenyl cyclase. So alpha 2 has got a mechanism which is different. Alpha 2 receptor activation leads on to inhibition of the adenyl cyclase. All beta receptors stimulate adenyl cyclase. Alpha 1 receptor activate. The mechanism is through the inositol phosphate. The pathways are little different. The second messages are different. Again, we'll study when the independent, the receptors are taken in detail. Now we go into the neurotransmission. There are 6 stages for the neurotransmission. There is the neurotransmitter, noradrenaline is the main neurotransmitter. It has to be synthesized, it has to be stored, it has to be released, it has to bind to receptors, it has to terminate the action of the norepinephrine and recycling of the precursor. So the neurotransmitter is the norepinephrine. Remember the 6 steps in the formation and the termination of the action of the norepinephrine. Let us see from where the hormone is produced. Not the hormone, the neurotransmitter. It is from the L-tyrosine. Tyrosine is acted upon by tyrosine hydroxylase, which produces L-dopa. That is dihydrophenylalanine. So dopa is the dihydroxyphenylalanine, L-dopa. This dopa is acted upon by dopa decarboxylase, which produces dopamine. So first is tyrosine hydroxylase, tyrosine 2 dihydroxyphenylalanine, which is acted upon by dopa decarboxylase to form dopamine. Dopamine is again acted upon by dopamine beta hydroxylase. That forms noradrenaline. So noradrenaline is formed from the dopamine by the action of dopamine beta hydroxylase. Noradrenaline is N-methylated. N-methyl transferase act on the noradrenaline, which forms adrenaline. This occurs in the adrenal medulla. So in the adrenal medulla, what is happening? The noradrenaline form is N-methyl transferase acts on, that forms the adrenaline. Noradrenaline is converted to adrenaline. In the adrenal medulla, it is converted into, methylated into epinephrine. Adrenal medulla, the release of norepinephrine is 20% and epinephrine is 80%.